We understand that these times remain challenging. CMI continues its mission to make it convenient for you to get premier outpatient care while deliberately making CMI the safe clinic for you and all those who are dear to you. Premier outpatient care is now available in the tip of your hands. With the same unhurried, meticulous attention, you can consult with CMI's broad range of specialists by phone, by video, or in person. For patients who prefer to see their doctor in the clinic, virtual patient screening for symptoms is mandatory prior confirmation of your appointment. We send online health declaration forms for you to fill out. Once your appointment is confirmed, you are all set to go to CMI. Since companions are not encouraged, patients are dropped off at the main entrance of Ori Central, where CMI is located. Kindly keep your mask on at all times. We want you to be safe in our clinic, right from the doorstep. Here are the clinic protocols we have implemented for your protection. Upon entering, your temperature will be checked by our care specialist. As we prepare your suite, you will be seated at our lobby while observing social distancing with other patients. You may get your snacks at our refreshments area, one patient at a time. Disposable cups for hot beverages have replaced reusable cups for the time being. Hand sanitizers and rubbing alcohol are also placed in key areas of the clinic for your easy access. Our doctors, care specialists, and staff are all wearing DOH-compliant personal protective equipment to ensure providing you with premier patient experiences. Your consultation is done in the privacy of a clean and spacious consultation suite. We also ensure to follow new normal processes for your physical therapy sessions and diagnostic procedures. Aside from our dentist and full personal protective equipment, we also use aerosol suction machines and acrylic covers during your dental procedures. If your doctor prescribed medicines, you may veer away from crowded drugstores as we have our pharmacy in the clinic for your convenience. We want you to be safe while in our clinic, even as we stay safe ourselves. All CMI staff undergo regular COVID-19 surveillance using Roche antibody screening. Lastly, CMI was conceptualized and built with your utmost safety in mind. CMI is on negative pressure airflow, and our high-efficiency particulate absorbing HEPA filters are built in. Since day one, we have been using UVC lamps to sanitize the clinic in between patients and after clinic hours. Also, our housekeeping staff regularly cleans and disinfects the consult rooms after each patient's use. In CMI, We are committed to provide the premier care you require and the safety you expect. Visit us at CMI for your outpatient medical needs.
Good morning, everyone, and we hope you are well. Centre Medical International, or CMI, is a premier outpatient clinic located in the heart of BGC. With over 150 specialists and subspecialists on our roster, CMI continues to be here for your medical needs, such as specialist consultations, by phone, video, or in person, diagnostic procedures, and preventive treatments, such as vaccinations and checkups. No crowds, no queues, no hassle. CMI is the safe clinic for you and all those who are dear to you. CMI is open Tuesdays to Saturdays, 8 a.m. to 4 p.m. Visit our website www.cmi.care or visit our Facebook page, facebook.com/cmi.care for the latest updates.
Good morning, friends and family. It is our pleasure to welcome you to CMI's three-part webinar series entitled Dementia, Detection and Prevention. Today, we have our first module, Yesterday, Today, and Tomorrow, a Talk on Understanding Dementia, by Dr. Donnabelle Chu, one of CMI's neurologists. This webinar series is in collaboration with and in support of Ms. Cathy Sanchez-Babao's advocacy on promoting the early detection and the prevention of dementia. She will be our moderator today, and CMI is honored to be part of this very important endeavor. And we are more than happy to be able to provide educational support to our friends and families through this webinar series. Ms. Cathy Sanchez-Babao has an MA in Family Psychology and Education from Miriam College, as well as a specialized training on the dynamics of grief in the family context from the University of Indiana. Previously, she has worked with various local and multinational companies as a communications expert, and she is also a grief counselor with her own weekly show on Facebook and YouTube. Ladies and gentlemen, it is our great pleasure to welcome Ms. Cathy Sanchez-Babao.
Good morning, everyone. I'm Cathy Sanchez-Babao, your moderator for this. Day. Good morning, everyone. I'm Cathy Sanchez-Babao, your moderator for this webinar series. Although it's true that memory complaints are very common as you grow older, it is also very important to make sure that you aren't blaming other kinds of memory trouble on just getting older or tumatanda lang, or that's part of aging. Acceptance, in early detection is always key, is always very important. And the earlier that you can get yourself assessed, so much the better. So CMI wants to make sure that we provide medical support in any way that we can, supporting each other as we continue with our mission of providing premier patient experience. In today's webinar, our speaker will share with us what we need to know about dementia. Before we proceed, just a few reminders. We will be muting everyone's microphones and turning off your videos for the duration of this webinar. For any questions, kindly type them in the Q&A box, which you can find, I think, either at the bottom or at the right side of your screen. We will group similar questions and have our speaker cover as much ground as we can. So as our speaker is presenting, you please feel free to put in your questions in the Q&A box. If you have not already done so, it would be great if you can include your full name to help us identify you properly for your questions and other matters where we might need to reach you. And now it is my pleasure to introduce our speaker, Dr. Donnabelle Chu. Dr. Donnabelle Chu is a practicing neurology specialist at the Centre Medical International at Bonifacio Global City. She finished her medical degree at the University of Santo Tomas and underwent neurology residency at the Makati Medical Center. Dr. Chu underwent observership in neuropathology at the New York Presbyterian Columbia University Medical Center in New York and was a clinical fellow for behavioral neurology and dementia at the University of British Columbia Hospital in Vancouver. She is a fellow of the Philippine Neurological Association and a member of the Dementia Society of the Philippines. She has published various researches and conducted numerous health talks on dementia over the years. Friends, ladies and gentlemen, let's welcome Dr. Donnabelle Chu.
Hi. Good morning, everyone. So, let me just share my screen before I start my talk. All right. So can everyone see my slides right now? So for this morning, I hope I'll be able to discuss with you and I'll be able to answer some of your questions regarding dementia. So my talk, as I've entitled it, is dementia more than just failing memory. So for today, we'll be able to know that dementia, it's not just all about memory complaints. There are other components in dementia. So let me start by saying that when people age, their nervous system begins to change as well. So the brain and the spinal cord lose their cells as well as their weight. Nerve cells start to decrease their productivity. They begin to transmit signals at a slower rate. So waste products begin to build up more and more in the brain. And this can lead to plaque and tangle buildup. So as you can see here in the slide, this is just comparing a brain of a young individual versus that of a normal elderly. So if you can see that in the brain of an elderly, there are tangles or the black plaques in the brain, which is expected in a normal elderly individual. So these plaques here can lead to a decrease in function of the brain. So as part of the normal aging of the brain, it is expected that as one age, the brain weight would drop. Parts of the brain, such as the ventricles, as well as the neurons or the nerve cells, would tend to become lesser. There is an increase in plaques and tangles, and there is a shrinkage of the nerve cells, the shrinkage of the brain itself, as well as the blood flow going to the brain would also be lessened as one ages. But these are all part of normal aging of the brain. But let us now know what dementia is. And we have to compare, and we will be discussing how one would know whether it is dementia or is it just part of the normal aging. So first, let me define dementia. So dementia is a decline from a previously attained cognitive level that affects activities of daily living or ADLs and social functioning. It is not a specific disease, but it is a syndrome or a group of disorders. It is often incorrectly referred to as senility or senile dementia, which reflects the formerly widespread but incorrect belief that serious mental decline is a normal part of aging. So symptoms of dementia would include memory loss, difficulties with thinking, problem solving or language, as well as changes in mood or behavior. So these symptoms should be severe enough to reduce a person's ability to perform everyday activities. So the National Institute of Aging in 2011 they made up a clinical criteria as to how one would diagnose to have dementia. So these are the criteria. Um, it includes that there should be presence of cognitive or behavioral symptoms that one should interfere with the ability to function at work or at usual activities. These symptoms or this cognitive decline should represent a decline from previous levels of functioning and performing, and it is not explained by any delirium or any major psychiatric disorder. So this cognitive impairment should have been detected and diagnosed through a combination of not just history taking from a patient and a knowledgeable informant, but as well as an objective cognitive assessment, either by a mental status examination or a neuropsychological testing by a physician. So they also stated in the criteria to diagnose all-cause dementia that the cognitive or behavioral impairment should involve at least two of the following domains. So there should be a decline either on the ability to acquire and remember new information, reasoning and handling of complex tasks, word judgment, visual spatial abilities, language functions, meaning speaking, reading, and writing, as well as changes in personality behavior or comportment. So these are the different cognitive domains. So learning or memory, complex attention, language, visuospatial, executive function, and social cognition and behavior. So the criteria states that if there is two or more decline in any one of these cognitive domains, accompanied by a decline in activities in daily living from a previous level of their functioning, it can be that individual can be diagnosed as to have dementia. So what are the activities of daily living? So activities of daily living can be divided into the basic ADLs and the instrumental or the complex ADLs. So when we say basic ADLs, it would include toileting, bathing, eating, dressing, grooming. Basically, it is all the activities that are essential in one's life. The instrumental or complex ADLs includes the tasks that we need to do every day, such as paying bills, budgeting, financing, driving or going around the neighborhood, cooking, shopping, marketing, as well as running a business. So if there is a noticed decline in terms of the activities of daily living, together with the decline from two or more cognitive domains, one can be diagnosed to have dementia based on the criteria given by the National Institute of Aging. So mild impairments would usually affect the instrumental or the complex ADLs first. So we have to note that we have to ask whether individuals would have difficulties in paying bills or budgeting in their shopping skills, running a business. These are all first affected and they are first noticed in the early stages of a cognitive impairment or dementia. So again, the dementia ABCs. So before saying that you have a dementia, you have to have dysfunction in the activities of daily living, cognitive decline, and then towards as the disease progresses, there is also a note of behavioral changes. So these three, the ABCs of dementia. So our next question is, how would you know whether is it normal aging or is it already dementia? So this table would just some of the symptoms or some of the commonly noticed symptoms of an individual. So how would you know that if you already have dementia versus it's just part of normal aging? So for example, in remembering things, so it is still considered normal when you're not able to remember details of a conversation or event that took place a year ago or even a month ago. However, if you you're not able to recall details of recent events or conversations, such as things that just happened yesterday or just happened last week, maybe you have some beginning dementia. In terms of being able to remember the name of a person, so it is normal if you won't be able to remember the name of your acquaintance or just an acquaintance or somebody that you just met or somebody you just uh, met once or twice. So it's still normal for you to forget that individual. However, if it is your family members or if it is somebody that you really know before that you start not to recognize or not to know anymore, then maybe it is beginning or you're starting to have symptoms of dementia. Normal aging also tends to have forgetting things and events occasionally, occasional difficulties in finding the words that you want to say, and you are worried about your memory, but your relatives are basically, or they are not too much worried about your symptoms. However, for dementia, it is also it is forgetting things or events almost every day or frequently. You have frequent pauses and substitutions and finding words. And here, your relatives are already worried about your memory problems, but sometimes you are not aware of any problems at all. So these are just some of the differentiating factors of normal aging and dementia. So basically, normal aging, it's just occasional forgetfulness, but for dementia, it is more frequent. So is it automatically just normal aging versus dementia? Is there no in-between stages? The answer is no, because in cognitive decline, um, forgetfulness can be part of normal aging. However, we must always keep in mind that this is not always the case. Consistent or persistent and especially worsening forgetfulness is never just part of normal aging. So progressive forgetfulness is a sign of cognitive decline. So these are the different stages of cognitive decline. So number one is the healthy aging, that you only have occasional forgetfulness. SCD, or the subjective cognitive decline. MCI, the mild cognitive impairment, and then dementia. So I will be discussing as to what's the difference between the SCD, or the subjective cognitive decline, and the mild cognitive impairment, as well as the dementia. So SCD, or the subjective cognitive decline, they comprises of group of patients with subjective concerns on declining cognition, but remains well on formal cognitive testing. There may be various etiologies of subjective cognitive decline, including depression, anxiety, and other general medical problems. However, researchers now are focusing on a select subgroup of patients with subjective cognitive decline because they think that these patients may have a high risk of developing degenerative dementia. So subjective cognitive impairment, or the subjective cognitive decline, it is characterized by self-experience of deterioration in cognitive performance, not detected objectively through formal neurological testing. So mainly SCI or SCD, subjective cognitive decline, it is just a self-experience of deterioration. However, when you do formal testing, when you screen their cognitive function, they are still normal, or they do well. Basically, they do well in neuropsychological testing or in screening of cognitive impairment, and it is just their subjective complaint. So they have subjective memory complaint. However, some would consider this as a stage prior to mild cognitive impairment. So when we say mild cognitive impairment, the difference here is now mild cognitive impairment is a condition in which individuals demonstrate cognitive impairment with minimal impairment in instrumental activities of daily living. So comparing this to the subjective cognitive decline in mild cognitive impairment, when we do cognitive screening or when we do neuropsychological examination, there is already a note of some decline in testing or in their scores. So the difference is that in subjective cognitive decline, it is just a subjective complaint of a cognitive impairment, but with normal uh, testing. But for the MCI or the mild cognitive impairment, there is a decline in cognitive function with impairment in their cognitive examinations based on the testing. However, there is no impairment in instrumental activities of daily living or only minimal impairment. So MCI can be the first cognitive expression of Alzheimer's disease, but can also be secondary to other disease processes. So the criteria for MCI is cognitive complaint, usually memory, preferably corroborated by an informant. There's cognitive impairment for age and education. However, they have essentially normal general cognitive function and they have largely preserved activity of daily living. So that is the difference among patients with subjective cognitive decline, mild cognitive impairment, and dementia. Because as you could remember, patients with dementia, their activities of daily living are already affected, and it is one of the criteria before saying if patient has dementia is the impairment in activities of daily living. But for MCI, the activities of daily living are largely preserved. So how common is mild cognitive impairment? So MCI is common in older populations and prevalence increases with age and lower educational level. So as one ages, the instance of or the prevalence of MCI increases as well. So for patients or individuals aged 60 to 64, the prevalence is 6.7%. And then going towards the overage, elderly 80 to 84, it is as high as 25.2%. But we should always remember that MCI may progress to dementia with a higher risk of progressing to dementia than age-met control with a relative risk of 3.3. However, we should also remember that not all patients with MCI would progress to dementia. A third of patients with MCI can remain stable and maintain that cognitive level. And the other third can revert back to normal cognition. So according to multiple class 1 studies, 14.4% to 55.6% of patients with mild cognitive impairment, they can revert back to normal cognition. So you will now ask, how would one, or how can we be part of this population? How can an individual with mild cognitive impairment revert back to normal condition? So we will be discussing that later. So what do we do in patients with mild cognitive impairment? So some cases of mild cognitive impairment are associated with reversible causes. It is not always due to Alzheimer's or any degenerative diseases. So patients with mild cognitive impairment need to undergo medical evaluation to determine presence of reversible causes. So again, as mentioned earlier, mild cognitive impairment does not always lead to dementia. Incidence rate of reversion to normal cognition among MCI individuals aged 65 years and older were noted to be up to 16% over 1 year in a clinic-based study and 28 to 55% in population-based studies over a 2 to 12-year period. So this is a graph of the cognitive decline. So again, one may have, everyone experiences slight cognitive changes during aging. So there is just a slight or just minimal cognitive decline or cognitive change, as you can see in the green arrow. During this stage, we have the preclinical or the subjective cognitive decline, wherein this is a silent phase. So the brain changes without measurable symptoms. Individual may notice changes but not detectable on tests, and it is a stage where the patient knows but the doctor doesn't. If this continues to decline, you can progress into MCI or the mild cognitive impairment, wherein cognitive changes are of concern to individuals and or of the family. So one or more cognitive domains are impaired significantly. However, as compared to dementia, in MCI, there is preservation of activities of daily living. But if cognitive changes continues to decline in patients with mild cognitive impairment. So from the dark blue line, it would become the red line, whereas it is considered now as dementia. So again, it is considered dementia if there is cognitive impairment severe enough to interfere with everyday abilities or from the activities of daily living. So dementia is further subdivided into mild, moderate, moderate to severe, and severe stages. So dementia, as mentioned by the World Health Organization, is a public health priority. So what are the symptoms? So again, difficulties with everyday tasks, confusion in familiar environments, difficulty with words and numbers, memory loss, and changes in mood and behavior. So again, as the title of my talk, dementia is more than just memory loss, and it's more than just failing memory. So it involves other cognitive symptoms as well. So who are affected? In 2015, it was estimated that 50 million people were living with dementia, and that it is expected to rise to 82 million in the year 2030, and it would become 152 million individuals would have dementia by the year 2050. So the number will almost double every 20 years. So take note that this study, or as mentioned by the World Health Organization, there are nearly 10 million new cases every year, and that one individual every 3 seconds is being diagnosed to have dementia. So it is becoming a health priority. It is really a public health priority now. So what is the cause of dementia? So conditions that affect the brain, such as Alzheimer's disease, stroke, and or health injury. So as I've mentioned earlier, dementia is not a symptom, but it is a syndrome. So again, it is an umbrella term used to describe a range of symptoms associated with cognitive impairment. So under the term dementia, it is caused by different entities. So the most common cause, and sometimes it is the misconception of individuals that when we say dementia, it is automatically Alzheimer's disease. But I would want you to know that Alzheimer's disease is just one of the causes of dementia, and it is the most common cause of dementia. So Alzheimer's disease accounts for 50 to 75% of dementia cases, followed by a different type of dementia, which is the vascular dementia, Lewy body dementia, as well as the frontotemporal dementia. So these diseases would manifest or would present differently. But the most common would be Alzheimer's disease. So the prevalence in our local settings, the most recent publication on the Philippine data revealed that the prevalence of dementia is to be at 10.6%. So it is estimated that around 726,000 individuals are currently living with dementia. This was published in the year 2018. So again, the subtypes or the different classes of dementia, this study in our country showed that 85.5% or majority of patients with dementia are of the Alzheimer's type. 11.7 is the vascular dementias, and 2.7% are other dementias. So what are the classifications of dementia? So this classification is based on which part of the brain is affected. So it is cortical dementia, subcortical dementia, reversible dementia, or the toxic and metabolic causes in the rapidly progressive dementia. So we have to know the different classes of dementia for us to know what we can do for the patient. So cortical dementia, here it includes the most common, which is the Alzheimer's disease. Under cortical dementia is also the frontotemporal dementia. Frontotemporal dementia is a type of dementia affecting younger individuals, and where presentation most of the time would be behavioral changes. So the difference between Alzheimer's disease is that Alzheimer's disease is commonly um, with memory problems of forgetfulness, but for frontotemporal dementia, it is more of a behavioral changes, Lewy body dementia, and the posterior cortical atrophy. Subcortical dementia, under it is the vascular dementia. So what is vascular dementia? So it's mostly, it is the common type of dementia that an individual would develop if that individual has vascular problems. For example, if a patient had the prior stroke, if the patient have history of heart disease, a history of hypertension or diabetes, so anything that affects our vascular health, it is prone or it may be a predisposing factor for a patient to develop vascular dementia. Parkinson's disease dementia is also under the subcortical dementia. Patients diagnosed to have Parkinson's disease, they eventually could lead to dementia as the Parkinson's disease progresses as they age, they could also develop dementia as well. Other types of subcortical dementia is the progressive supranuclear palsy. We have also to remember that not all dementias are the types of neurodegenerative disease. There is such a thing as the reversible dementia. They are mainly caused by toxic and metabolic causes. So drugs and toxins can cause dementia symptoms. Metabolic dementias, meaning any problems with our electrolytes, for example, we have low sodium or high creatinine. So any metabolic problem. Vitamin deficiencies can also manifest with symptoms of dementia. Tumors of the brain can manifest with symptoms of dementia as well as infections and alcoholism. So we have, because of this reversible dementia, it is important for us to really evaluate patients with symptoms of dementia for us to be able to identify what type of dementia they have, so that if we find that they have reversible dementia, we would be able to treat this cause and to revert the signs of the dementia. So the last classification of dementia is the rapidly progressive dementia, but this type is not that common, or it's very rare. So given that Alzheimer's disease is the most common cause of dementia, I'll be discussing more on Alzheimer's disease. So Alzheimer's disease is a neurodegenerative disease and is the most common type of dementia. It is more common in the elderly population, hence there is an increase in the aging population. Worldwide projections of Alzheimer's disease prevalence increases as well. So it is estimated that by 2050, 106 million individuals will have the disease. So Alzheimer's disease is a neurodegenerative disease of the brain presenting with gradual loss of memory, judgment, and ability to function. So it usually appears in people older than the age of 65. So again, the National Institute of Aging had come up with the clinical criteria for probable Alzheimer's disease. So they state that it should meet the criteria for dementia, the all-cause dementia, as I've mentioned earlier. And in addition, it should have the following characteristics. It should be insidious in onset. There is a clear-cut history of worsening of cognition by report or observation. And the initial and most prominent cognitive deficits are evident on history and examination in one of the following categories. Amnestic presentation, meaning it is the most common presentation of Alzheimer's disease, forgetfulness. However, other manifestations such as language problems, visuospatial, or executive dysfunction may also be considered. So the diagnosis should not be applied when there is other disease entities. So what causes Alzheimer's disease? So our brain has different proteins. Examples of these proteins are the beta amyloid. However, if there is abnormal metabolism of the beta amyloid plaques, it would cause buildup of these plaques as shown in the picture. So if you would compare the picture of a normal brain, it's just, you could see just the neuron or the nerve cells. However, if there are buildup of the plaques, such as the amyloid plaques, it may cause or it may trigger formation of neurofibrillary tangles inside the nerve cells, which would lead to the symptoms of Alzheimer's disease or shrinkage. So again, here, if you could just see that there are buildup of the abnormal proteins or the amyloid plaques, as well as the tangled tau protein, which would all manifest as cognitive decline. So here is just a diagram of the risk factors for Alzheimer's disease. So non-modifiable risk factors are the genetics as well as age. Age is the number one risk factors for Alzheimer's disease. And the different modifiable risk factors is, so if you have these risk factors, it would cause accumulation of the lesions or the accumulations of the different proteins, such as the amyloid plaques or the amyloid protein, the tau protein, and the other proteins in the brain. So if once there is accumulations of lesions, it would lead to the degeneration of the nerve cells or the inflammation as well as death of the neurons of the brain. And with the degeneration of neurons or the nerve cells in the brain, it would manifest with the symptoms of cognitive decline. So what are the types of Alzheimer's disease? So there is the early onset AD and the late onset Alzheimer's disease. So for the early onset, it is usually the familial type. The onset before age of 65. However, you should know that it is only 5 to 25% of the cases. So you would ask whether if you have a family member or family history of having Alzheimer's disease, would you automatically have Alzheimer's disease as well? So the answer is you are at risk to develop Alzheimer's disease, but by the age, if you're already at the age of like 60 and you still haven't developed any symptoms, then maybe you would the risk of you developing Alzheimer's disease because of your family predisposition lowers. So familial Alzheimer's disease is due to mutation in 3 different genes. Now next is the late onset Alzheimer's disease or the sporadic. So this is the more common type of Alzheimer's disease, and it affects 75 to 95% of the cases, and this usually affects individuals more than 65 years old. So again, there is no causative gene identified yet. However, it is caused by different factors, such as increasing in age, genetic susceptibility, environmental factors such as vascular health, mental stimulation, sleep, head injury, and depression. So what are the symptoms of Alzheimer's disease? So again, the most common symptom is memory loss. There's gradual loss of ability to perform normal tasks, loss of vision and coordination, and so forth. So there is also mood changes. So the progression again, so from the preclinical to MCI, dementia, or the Alzheimer's disease. So the progression of Alzheimer's disease is that first you have mild cognitive impairment. So if this progresses, it would be into mild Alzheimer's. Usually, symptoms here would include reading problems, poor object recognition, poor direction sense. And then it would become moderate Alzheimer's. Symptoms now would include poor judgment, impulsivity, and short attention. So stages and severity of the Alzheimer's disease. So mild is difficult with finances, counting money, travel, communication, memory loss increases. Moderate do not need assistance with toileting, but needs help in choosing clothing and not oriented to date anymore. Moderately severe requires more assistance with ADLs such as bathing, toileting, and eating. And during this stage, an individual may develop delusions, hallucinations, or obsessions, or what we commonly call the behavioral and psychological symptoms of dementia or BPSD. So in this stage, patients may have increased anxiety and may become violent. And for the severe stage of Alzheimer's disease, it is wherein the individual would have urinary and bowel incontinence, speech is lost, and sometimes this is the part where they are just bedridden and they are fully dependent with ADLs. So in terms of the BPSD, this is just the common symptoms or behavioral symptoms of patients with moderately severe Alzheimer's disease. agitation, aggression, disinhibition, anxiety, delusions, and hallucinations. So the disease progression or the prognosis is that usually it would last 3 to 11 years after diagnosis, and some may also survive 20 years for more than 20 years. In Alzheimer's disease, the death of an individual with Alzheimer's disease is usually from concomitant medical conditions such as infections, malnutrition, injury, or falls, and not the Alzheimer's disease per se. So how do we diagnose with patients with Alzheimer's disease or dementia in general? So it is based on careful and thorough medical history, physical examination, as well as cognitive assessment. So you have to see a doctor for the doctor to be able to do cognitive assessment for you to be able to know whether you have MCI, subjective cognitive decline, or you have early signs of dementia. Laboratory examination should also be done for us to rule out any of the reversible causes of dementias as mentioned earlier. Neuropsychological examinations as well can be done. Brain scans such as CT scan and MRI and PET scans. This is for us to really rule out reversible causes of dementia and as well as see whether your brain is shrinking already or any particular part of the brain is affected, which may explain your symptoms. Blood amyloid levels, as I've mentioned earlier, the Alzheimer's disease is caused by abnormal accumulation of the protein amyloid. So there are tests now that can determine the level of the blood amyloid in our body for us to say whether you have possible Alzheimer's disease or not. Amyloid PET scans are also available. However, these tests are presently not recommended for clinical use. So treatment for Alzheimer's disease, unfortunately, there's still no available cure for Alzheimer's disease. So the available drugs are all for symptomatics. So these drugs work by regulating neurotransmitters, the chemicals that transmit messages between neurons. They may help reduce symptoms and help with certain behavioral problems. However, these drugs don't change the underlying disease processes. So drugs such as the acetylcholinesterase inhibitors, donepezil, rivastigmine, the NMDA receptor antagonists or memantine, they work in preventing progression of symptoms but not reverse the cause of the disease. So it's just prolonging the decline in the cognitive impairment. And then you may ask, how about the supplements? Are they useful for us in preventing developing cognitive impairment? Supplements have not been proven to be effective in prevention of progression of dementia symptoms. A growing number of herbal remedies, dietary supplements, and medical food are promoted as memory enhancers or treatment to delay or prevent Alzheimer's disease and other dementias. However, the claims about the safety and effectiveness of these products, however, are based largely only on testimonials, tradition, and a rather small body of scientific research. So studies have been made, however, it involves only few numbers of subjects, so it is still not recommended. However, if you would want to try to take the supplements, there's nothing against you taking supplements. However, do know that these are not yet proven and it is not yet recommended by doctors and researchers. So screening for cognitive impairment, why is it important? So screening for dementia is important because the importance of early diagnosis is that if we find that you have an early stage of dementia, we can initiate early treatment that may slow down the progression, as well as it could help in care planning for the family, knowing that the dementia is a progressive disease. So it is important of doing cognitive screen for the elderly population, and it's actually recommended now that senior citizens or even individuals at the age of 60 be screened for any cognitive impairment for us to know whether they have signs of mild cognitive impairment or early dementia, so that we could do some of the preventive management for them not to develop into dementia later on. So there are biomarkers for MCI. So these are again tests being used in research studies to know whether a patient would have Alzheimer's disease or not. So beta amyloid CSF, tau CSF, plasma beta amyloid, the FDG PET scan, and the amyloid PET scan. As MCI has been known to be a preclinical form of AD, biomarkers used in diagnosing AD has been suggested to be utilized in patients with preclinical AD or MCI. However, these tests are still undergoing a lot of clinical trials to determine its use clinically. So there is still an ongoing debate whether is it useful to do such tests in a clinical setting. Some would say that doing this test in patients with MCI, whether it's so that they would know whether they are at risk to have the Alzheimer's disease, has its their own pros and cons. One of the cons would be the psychological factor. So they mentioned that sometimes for an individual to know that they have this amyloid protein, it would maybe cause depression or even anxiety. However, some individuals would say that they would rather want to know so that they would be able to prepare for the future in terms of planning. And then some of the components against the biomarkers for MCI would say that what would be the use of doing these biomarkers if there's still no treatment yet. So there are different pros and cons in doing these biomarkers or doing this test in patients with mild cognitive impairment. So basically now it is still not recommended for us to do biomarkers for MCI. So the knowledge of the use of biomarkers in patients with MCI is a rapidly evolving field. However, no biomarkers clearly shown to predict progression in patients with MCI. So, so then the question is whether we do the biomarkers or not. How do we prevent progression of patients with MCI? How do we prevent it to further decline into dementia? And how can we revert back to normal cognition? So as I've mentioned earlier, these are the different risk factors for dementia. So the vascular risk factors: hypertension, dyslipidemia, smoking, obesity, type 2 diabetes, heart disease, stroke, and hyperhomocystinemia. So these are the modifiable risk factors. So as long as we treat or we prevent hypertension, we control our cholesterol levels, we stop smoking, we manage our weight, so the risk of developing dementia decreases. And then the protective factors include high education, high occupational position, active lifestyle, extensive social network, as well as cognitive activity. So these are the protective. So we must engage with active lifestyle and extensive social network for the brain to be protected. So these are the modifiable risk factors of dementia. So again, 35% of all dementias are attributable to these risk factors. So we have to address these risk factors so that we'll be able to prevent development of dementia. So the World Health Organization recommends that for both adults aged 18 to 64 and 65 years above, they should do at least 150 minutes of moderate intensity aerobic physical activity throughout the week, or at least 75 minutes of vigorous intense aerobic physical activity. The best current evidence also suggests that heart-healthy eating patterns such as the Mediterranean diet may also help protect the brain. A Mediterranean diet includes relatively little red meat and emphasizes whole grains, fruits and vegetables, fish and shellfish, and nuts, olive oils, and other healthy fats. So again, the World Health Organization guidelines in 2019 recommends that physical activity should be recommended to adults with normal cognition to reduce the risk of cognitive decline. Physical activity may be recommended to adults with mild cognitive impairment to reduce the risk of cognitive decline. Cognitive training may be offered to older adults with normal cognition and with MCI to reduce the risk of cognitive decline and or dementia. So can we reduce the risk of having dementia? The answer is yes. So how do we reduce the risk? So number one, look after your heart. You have to take care of your uh, general health, the cardiovascular health. You have to be physically active, as stated by the World Health Organization. You have to do at least 3 to 4 times a week of moderate intensity aerobic exercise for about 30 to 45 minutes a day. You have to follow a healthy diet. You have to remember that you need to challenge your brain and you have to enjoy social activity. So you have to engage in cognitively stimulating work or volunteer in something meaningful. You have to consider yourself a lifelong learner and utilize community resources for continuing education. So tips for coping with normal age-related memory difficulties, you have to keep a routine, you have to organize information, you have to keep details in a calendar or a day planner, you have to put items in the same spot, repeat information, make associations, involve your senses, and teach others, as well as you have to get a full night's sleep. So before I end my talk, now that we are in this new normal, COVID-19, I just briefly discuss COVID-19 and dementia. So the impact of COVID-19 pandemic is greater in vulnerable individuals, mainly the elderly, people with chronic medical conditions, immunosuppressed individuals, as well as persons with cognitive impairment and psychiatric diseases. So people living with dementia have limited access to accurate information and facts about the COVID-19 pandemic. They might have difficulties in remembering safeguard procedures such as wearing of masks, ignore safety measures that could expose them to the infection. So the concerns for patients with dementia, they have increased risk of infection with COVID-19 with higher morbidity and mortality. So social and personal restrictions likewise increases the likelihood of worsening of dementia, both on the cognition and behavior. Older adults, especially in isolation, and those with cognitive decline or dementia may become more anxious, angry, stressed, agitated, and withdrawn during the outbreak while in quarantine. So there are different changes in caregiving. There are more caregiver burden in patients with dementia. So patients with dementia may not understand changes in their routine and become agitated. Advanced dementia patients with limited comprehension would require caregivers to assume the responsibility to keep them safe. So not only are patients with dementia affected, but also as well as their caregiver, because caregivers might also have their own anxiety due to the pandemic, plus they have to care for the patients with dementia more. So it causes a lot or increase in caregiver burden. So what are the effects of social restriction on patients with dementia? So they have disrupted routines for people uh, living with dementia, loss of access to family and social support in terms of administration of medications, worsening of cognition and behavior, increased stress on caregiver, as well as disruption of healthcare services because people, especially the elderly, are in the vulnerable stages. Some of them are afraid to go to the clinic. Some of them would rather stay at home and not consult their doctors. However, we have to note that given this time, we are given our technology nowadays, we are also slowly using telemedicine in terms of consultation. CMI is a safe environment. So you have to know that even with the pandemic that is going on, you have to have your elderly be checked and assessed by doctors. So this is just some of the tips during COVID-19. So are you living with dementia or are you having mild cognitive impairment? So you need to try to continue with your daily routine as best as you can. You have to call loved ones via phone or video calls, play games that exercise the brain. So even if you are in quarantine, even if you're just staying at home, you have to keep your brain active. You have to keep doing things. You have to write down reminders, do gentle exercises. You have to continue doing aerobic physical exercise, as well as connect with other people through Viber, through Zoom, or any of the internet or the different social media platforms. So this is for the caregivers. So are you caring for a person with dementia? So try to keep in regular contact with loved ones via phone. Place reminders around the house to wash hands, exercise regularly, try to keep a regular daily routine for them. And you have to avoid these things. You avoid scare tactics. You avoid unnecessary use or media noise or unscheduled napping, or even avoid to get upset if the person with dementia is confused by the situation. So tips again, consider placing signs to remind persons living with dementia to wash hands with soap for 20 seconds. So you just have to increase your patience in terms of dealing with patients with dementia now during the time of COVID. So with that, thank you, and we are now open for questions.
Thank you very much, Dr. Chu. That was really very helpful and very informative. I actually learned a lot. So we have several questions from our audience. The first one is, hi, good morning. The result of my brain MRI says my blood vessels are narrow. That is why there isn't enough flow of oxygen most of the time, and it causes severe headaches, which leads to seizure twice. My neurologist said I am a candidate for dementia when I grow old. I'm 50 now. Is this true, and what can I do to avoid dementia?
So I've already mentioned earlier that again there are different types of dementia. So maybe your neurologist that mentioned that you might be a candidate for dementia, maybe he or she was thinking about vascular dementia, because it's again vascular dementia is caused by uh, diseases that affects our vascular component like hypertension, diabetes, and if the brain lacks oxygen, so it is a risk factor for you to have dementia. So how do you prevent it? How do you avoid dementia? So again, I've mentioned it in the talk. So you have to keep on doing physical exercises, aerobic exercise, avoid the risk factors. So again, you have to take care of your health and keep your brain active, avoid stress, avoid being depressed. So just avoid all the risk factors for dementia and eat healthy.
Right. Okay. Thank you, Dr. Chu. Next question. Okay, I think some of these are answered now. Okay. What are the possible reasons of early onset dementia? Like, let's say, between the ages of 45 to 55.
Okay. So again, there are different types of dementia. So as I've mentioned earlier, an example of a dementia that occurs in younger populations are the frontotemporal dementia. So these usually would manifest with behavioral problems, behavioral symptoms. So they are common in younger individuals. But however, if you, I'm not sure whether you are pertaining to Alzheimer's disease. Uh, so sometimes, yeah, as I've mentioned, early onset Alzheimer's disease is mainly due to familial or those that have family history of Alzheimer's disease. However, they are not common actually. Most of the time, it is the sporadic Alzheimer's disease. So for younger individuals with dementia, it might also be because of the reversible causes of dementia. Maybe that young individual have symptoms of early dementia because they have problems such as metabolic problems, or maybe they have the reversible causes. Maybe they have something organic in the brain, or maybe they have problems with the thyroid because problems with thyroid glands or patients having hyperthyroidism or hypothyroidism, they also manifest with symptoms of dementia. So in younger individuals with possible or possible symptoms of early dementia, again, it is important that you have them screened. So whether they sometimes actually depression also manifests as parang symptoms of dementia rin eh. So sometimes people would say, ay, may dementia ka na. But when we do some testing, it's because pala they are depressed. So parang yung presentation nila is makakalimutin, presentation nila is wala silang gana, parang wala sila sa ano, it's a problem of mood naman. So it's not common to have symptoms of dementia in ages 45 to 55. So we have to really have them checked na lang and screened.
Right. Okay. What if you pass all the dementia tests, also for Alzheimer's and for vascular dementia, but still symptoms are behavioral change and cognitive decline? What would the MRI scans be able to tell, and how do we engage with this individual?
And so basically, the MRI scans will be able to tell us, they would be able to show us in general what your brain looks like. So do you have atrophy or meaning shrinkage of the brain? If there are particular parts of your brain that has shrunk, or are there any possible causes of the symptoms, even if you pass the dementia test, that would explain the cognitive decline. Maybe you could also see the vascular changes. You can see that in the MRI. So maybe you have symptoms of dementia because of the vascular changes. So if we see that it's because of the vascular changes that's causing the symptoms, how do we engage with this? So we have to treat those vascular problems. We have to control hypertension. We have to manage, for example, if you have diabetes. So basically, you'd be able to MRI scans would let us know the picture or the current status of of your brain for us to know what to do with the symptoms and how to prevent further decline.
Yeah, and I think she also asked, how would you engage? Siguro maybe the person doesn't want to. I'm just guessing, doesn't want to accept that there's a problem. So how do you suggest that they approach? I'm guessing this is a family member. How do you suggest they approach a family member, or in general, how would you approach a family member who napapansin nyo na, and you probably suspect that there's something amiss, but the person themselves, of course, they refuse to accept it. So what's the best approach, Dr. Chu?
Actually, it's common na parang kasi 'di ba patients with dementia, they sometimes don't have insight rin. Their insights are affected. So most of the time, patients with dementia, they won't say, parang they would feel na I'm okay, I don't have problems. Parang they don't accept, especially and sometimes it causes the problems pa among the family members kasi nga parang the patient herself would say, wala akong problema, bakit niyo ako inaano na may problema. So basically what I advise to patients or to relatives here is you have to understand the patient. So sometimes you have to parang ang inano ko nga is wag niyo nang anuhin sa kanila, hindi may problema ka. Don't do that na kasi they would argue pa more. So parang you have people, we just have to maybe go to the doctor for us to know that you are doing well. We have to have you check para so more of parang don't tell na punta tayo doctor kasi may problema ka. Don't do that. Parang let's just have you check para we have to make sure that you are perfectly well, you are healthy, for us to be assured that you are doing good. So basically, it's just sabihin nyo na parang it's a routine check-up lang. Don't mention na parang you have to be checked because you have dementia. So parang more of, it's for general na regular annual check-up nyo lang to, yung mga ganun. So medyo aanuhin lang natin yung patient.
Mahirap. Pag dediretsuhin mo, lalong hindi pupunta yun di ba?
Okay. Lalo silang magagalit. Kaya mas hindi sila papayag lalo.
So, there's a question. My mother is 92 years old and clearly has exhibited those symptoms, inability in ADL and complex ADL. She has never been checked by any neurologist or assessed. Do you still recommend she undergoes it? The only activity she is able to do alone is eat. What would be the consequences if we do not have her checked?
So again, 92 na the question is it baka naman kasi it's part of her age na. That's why, kasi diba, it's expected na rin as one ages, parang affected, 'di ba, parang it's part of normal aging that our brain would shrink na.
Yes.
So baka talaga kanya siya exhibiting parang inabilities of ADLs na and complex ADLs. It's because matanda na talaga siya. And ang ano dyan is she exhibit, parang I don't base here lang on the age, but she does not have parang mga behavioral symptoms pa naman, and she doesn't have any mga yung mga aggressiveness and agitation or any behavioral symptoms. And it's just because of her baka memory. Baka it's part of her age na lang and it's not dementia. Parang ganon. Kasi wala siyang other symptoms of the dementia. Kasi 'di ba, yung progression ng dementia is the longer or the parang the severe the stage is as one grows older, mas marami magiging problem. Pero if she's 92 but no other problems, I think it's best pa rin to have her check parang in general health pa rin lang. Para ano.
What type of vitamin deficiency can possibly cause reversible dementia?
Vitamin like B12 deficiency, vitamin B12, yung mga folic acid, vitamin D. They are all, some of the tests nga rin that one would request, vitamin B12 determination, vitamin D level. So these are the vitamin deficiencies.
My mom is 88 years old. She always asks about her parents. She remembers her siblings rather than her children. But she will remember it when we help her recall. She sometimes thinks that someone is trying to kill her. Is this dementia?
So that is the reason as to why your mom would tend to remember yung mga medyo sa old, yung parang sa lumang memory na. It's because there's a certain part of the brain or the hippocampus. It is kasi yung memory, parang yung the process of memory formation sa atin. Parang it's being encoded muna and then it would be stored. Pero ang nagiging problem habang tumatanda tayo, the part of the brain that is involved in yung encoding is affected. So yung mga new information, ayun yung parang ano na, yung mga recent and the newer information, they tend to be lost first. Kumbaga na ano, and then what is retained is yung mga luma na. So parang kaya ang naaalala talaga nila is more of yung mga old memories kasi yun na yung mga unang na-store, and then yung mga recent memories are the one na unti-unting unang-unang na nawawala. So I'm sorry, what's the second part of the question?
Let me double check. The mother is 88. She sometimes thinks that someone is trying to kill her. Is this dementia?
I think parang pwede, it's part of the ano nga, in behavioral, like the paranoia. Right. So pwedeng ano rin siya, parang symptoms of the behavioral and psychological symptoms of dementia.
So I think the best would be to bring your mom, diba, for an assessment. Although she's 88 years old, so it could be a challenge nowadays, but still possible. Okay, we have last two questions, Doctora. Is it true that doing crossword puzzles, Sudoku, and other mind exercising games can help prevent dementia?
Yeah. Actually, what's really important is it's more of social interaction. Mm-hmm. Kasi when parang yes, Sudoku and kumbaga it's a brain exercise. But it's again parang passive lang siya kasi ikaw lang eh. It is better if you have an active parang participant, parang like social interaction. So you engage with yung mga discussion, you engage with group activities para mas na-challenge yung brain. Yes. And although parang the Sudoku, the crossword puzzle, it's also good. Pero what I always tell nga is as long as you enjoy those activities, do it kasi it helps naman. Pero kung hindi ka marunong mag-Sudoku, tapos pinipilit mo maglaro ng Sudoku, baka mainis ka lang and then it would cause frustrations pa. So more of kailangan you enjoy what you're doing, and then in social interaction, it's really one of the proven ways to prevent dementia. You have to keep your brain active. You have to engage with discussions with other people. Na yun nga, parang ngayon sinasabi, how do we do that? Naka-isolate tayo. But remember, we have the technology now, like this, Zoom. You can have mga online discussion pa rin. You can ask your friends na, uy, let's meet naman sa Zoom once in a while. Para may ano pa rin kayo, may interaction with other people. So yun yung important.
Agree. Very important talaga. I read that somewhere also. Social interaction is very important. I know of groups of mga women who are like in their late 80s, early 90s, and super pa yung cognitive nila. Their thing is mahjong every afternoon. So,
yes. Yeah. Actually, mahjong. And then actually now, there's an ongoing study here sa Philippines about dancing.
Yeah, right.
Parang, ang ano nga, kasi diba, parang dancing, it's both physical activity, kasi diba, you move around, you dance, and then you have like yung mga ballroom dancing, you have a partner, so may may interaction ka rin with other people, plus you use your brain yung sa steps niya, diba? So parang na-challenge din yung brain mo to remember, to memorize kung anong steps ang kailangan, ano. So parang all in ano na siya, physical, mental, social interaction. So dancing it's one of the parang recommended na activity na to prevent dementia and cognitive decline.
So maybe dapat next year pag wala ng COVID, magkaroon ng di ba, rise in dancing classes, ballroom dancing classes.
Mm-hmm.
Okay. All right. Before I give the final question, I know there's so many questions, so CMI and Dr. Chu will try to respond to it either via email or on their FB page. Okay. The final question is, are hallucinations a part of dementia, and what should the caregiver do when the patient starts hallucinating?
Ayun. Yes, hallucination is part of the behavioral and psychological symptoms of dementia. Actually now, a lot of people na before they were not diagnosed to have dementia, pero bigla silang would come and consult na, doktora, nag-hallucinate yung matanda. It's possible that before they have early signs of dementia, but parang biglang sila nag-hallucinate kasi something might have triggered it. What I usually would want is to rule out infection. Kasi it's possible na meron silang early signs of dementia before, but then nagkaroon sila ng infection. So mas pumangit bigla yung cognitive decline nila. Kaya mas biglang naging mabilis yung pag-progress and they developed hallucination. Or maybe, baka lang because of the infection, hindi pala dementia talaga yon, but it's part of yung mga delirium. So, you have to, parang pag new onset na nag-hallucinate yung elderly ngayon, you have to rule out na may infection siya or any metabolic causes. Again, yung mga reversible causes po. So, yun.
Okay.
And what do you need to do? So, yun, have them check. And if na-rule out, for example, you have them check na, and you have ruled out mga reversible causes of the hallucination, so your doctor they'll be able to help you, parang they can prescribe medications to control hallucinations and all.
Okay. Wow, Dr. Chu, ang daming questions. So, like we said, we'll try to answer the rest via email or on the Facebook page. But thank you very much, Doctor, for giving us your time this morning. If you want to contact Dr. Chu, I think we can show CMI's and her contact details on the screen. CMI is open Tuesdays to Saturdays, 8 to 4 p.m. And you can also visit the website at cmi.care or the Facebook page. Okay, they have a Facebook page, facebook.com/cmi.care for the latest updates. This series still has a part 2 and a part 3, so we'd like to invite you to complete the dementia series, diba? Para use the pandemic to enhance your knowledge, and sabi nga, knowledge is power. So if you suspect that you might have a family member who has dementia, then We will provide you with even more information in our next 2 modules. I believe it's the next two Fridays or Thursdays of the month, but we'll flash the details in CMI's Facebook page, and I'll post it also on my Facebook page. So thank you all. Thank you so much. Thank you to CMI for hosting this program. So I learned so much, and I hope our attendees also you learned a lot of things today. You will learn even more things if you join us for part 2 and part 3. So thank you very much. Keep safe and have a blessed weekend.
Thank you, everyone, and keep safe.